Hello, I'm Robert Purchase, an orthopedic surgeon here in San Francisco, California, with a specialty in shoulder surgery and sports medicine. Thank you for your interest in this topic. My intent is to quickly explain some of the more commonly seen sources of shoulder pain and how they can be treated. Thank you for your interest, and I hope you enjoy. A complete list of entities that cause shoulder pain would require a much smaller font. This above list does not even contain any traumatic causes, but the point is clear. Many things can cause shoulder pain. I'm going to focus on the top three here: the subacromial impingement, tendinitis of the biceps, and arthritis of the AC joint. While it's very difficult to say what exactly is the typical shoulder patient, one of the most common presentations of shoulder pain involves a combination of these three entities. Subacromial impingement, which is also known as rotator cuff impingement. This can cause rotator cuff problems such as tendinitis or even tendon tears. Degeneration of the acromioclavicular joint, or the AC joint, is common, as is tendinitis of the long head of the biceps. All three of these can exist in isolation, or a combination of two or three, or even all three can be symptomatic in an individual shoulder at any one time. When you look at the normal anatomy, focusing on the most commonly painful rotator cuff muscle, the supraspinatus, you see that it travels under this arch, formed mostly by this bone, called the acromion. So there's a space under that bone, under which the rotator cuff tendon glides as you raise and lower your arm. But if something narrows that space, the tendon can get pinched or impinge and becomes painfully swollen. One of the most common causes of narrowing that space are spurs on the front of the acromion. Here is the classic standard classification scheme, which was proposed by Bigliani, where type 1 is normal. You can see it's flat, type 2 is curved, and 3 is hooked, and these are obviously abnormal. And you can see that they very subtly narrow the outlet for the rotator cuff tendon to glide. So plainly put, if you have a spur on the front of your acromion, as seen on this x-ray, you can pinch your rotator cuff on that spur as you raise your arm, causing inflammation and pain. Most patients are candidates for an initial attempt at non-operative measures. Non-operative measures including activity modification, anti-inflammatory medications, and physical therapy have been shown to be effective in a majority of patients without rotator cuff tendon tears. One note in particular: an injection for subacromial impingement, rotator cuff tendinitis, is put into the subacromial space. That's the space below the acromion, above the rotator cuff, and bathes the inflamed area in the anti-inflammatory cortisone. A new technique using ultrasound can improve the accuracy of these injections. If surgery becomes necessary, it is a relatively easy technical exercise to remove that spur arthroscopically. So the first thing that you see arthroscopically is the fraying of the soft tissue on the undersurface of the acromion. That frayed tissue is covering the spur. If you look opposite of that frayed tissue, you can see the scuffing on the top of the rotator cuff tendon. When you see the combination of the two, this basically confirms that diagnosis, meaning that you've essentially proven that that rotator cuff has been pinching on that spur when you move your arm. If you look back at the undersurface of the acromion and then remove that frayed soft tissue, you can see this spur. Once the spur is visualized, it can be removed with the arthroscopic bone burr. Moving on to arthritis of the AC joint, where the clavicle or collarbone meets the acromion, there's a little joint called the acromioclavicular joint. Most people simply refer to it as the AC joint. Very often, it can develop arthritis, seen on the x-ray as bone spurs. Non-operative treatment is focused on controlling symptoms with activity modification, anti-inflammatories, and/or Tylenol. In select cases, an injection into the AC joint itself can provide significant relief. If non-operative measures fail, the very end of the clavicle or collarbone can be removed, again with an arthroscopic bone burr. This stops the two ends of bone from touching, which stops the pain. Since you do not take too much of the bone off, the joint remains stable and there's no functional deficit. So once you recover, the pain that the patient was having from that joint is gone. This is called a Mumford procedure. The biceps has two parts at the level of the shoulder: the short head, which is outside of the shoulder joint, and the long head, which starts at the top of the cup of the shoulder, traverses the interior of the shoulder joint, and makes a 90-degree turn to go down the arm where it eventually meets the short head. The long head of the biceps can get inflamed and painful from either overuse or from impinging on that same acromial spur. Similar to subacromial impingement, non-operative measures include activity modification, anti-inflammatories, physical therapy, and an injection can often be tried. For an injection directed at a painful biceps tendon, I inject into the shoulder joint itself. At the time of surgery, a painful biceps tendon will look red and inflamed, or sometimes even partially torn. If surgery is necessary, there are two options, either a biceps tenotomy or biceps tenodesis. A biceps tenotomy involves simply snipping the biceps tendon at its base. A biceps tenodesis requires cutting it from its base and reattaching it somewhere else where it is out of jeopardy. There are pluses and minuses to both of these approaches, and it's a topic of conversation all by itself. The short version of the story is that both are effective in taking care of pain from biceps tendinitis. To summarize, it is common for patients to have pain coming from more than one anatomic site. To say that non-operative measures have failed and therefore surgery is indicated, you must ensure that non-operative measures have been directed at all painful conditions. Similarly, one must recognize and address all painful sites at the time of surgery to increase the likelihood of a good surgical outcome. These comments really only scratch the surface on each of these topics, and here are some links for more information if you're interested. Thank you for your time and attention. Now please remember, as always, all comments in this video and on this site, including the comments contained within, are general in nature. They do not apply to any specific clinical scenario or any individual patient. The comments are meant to provide general background as an introduction to complex topics. The comments posted here are not meant as medical advice, nor they should be regarded as a substitute for examination, diagnosis, and medical care provided by a licensed and qualified health professional. All listeners and readers are encouraged to see their personal physician. All cases and clinical information presented represent examples of general themes, presentations, or issues. They do not represent a single case or the information of a particular patient. Your feedback and comments are encouraged. However, please do not post any information that can identify any individual, including specific questions regarding medical care. Any such postings may be deleted. Have a good day.